Hi, it's Dr. Noel Williams, Oklahoma City, Oklahoma, Optimal Health Associates. COVID update, October 21st, 2020. So, news of the day. Cases are still skyrocketing here. Still about 870 patients in-house at the hospitals. Lots of transfers going here and there and everywhere with people who are sick and need hospitalizations. The hospitals are saturated. On the positive side, the Oklahoma Hospital Association president successfully has gotten the governor's office to move. Patty Davis, who I've known over the years, wonderful leader, healthcare administrator, wonderful professional, has gotten with the governor's office, and they actually have announced a plan. Today the governor did an announcement yesterday. Last week, the governor's office, to be clear, wasn't very interested in any of this, even though I think a lot of people on the healthcare administrative side wanted him to be. And again, this is what's going on behind the scenes that people don't know, but it's the truth. And thankfully, enough hospital people, administrators, the Hospital Association, convinced the governor that it was important that we don't run out of beds for all our patients. So we're in tier 1, meaning 15%. Once we have 15% of hospital beds filled with COVID patients in I believe our tertiary care facilities in a region, and they've based it on the trauma regions, which I've talked about in the last few weeks, which is what we were hoping for. If we cross that, we go to level 2, and then there's level 3 and level 4. And God willing, we'll stay at level 1, but there's a possibility we could go to level 2 or even level 3 if it gets really bad. But hopefully it will stay at level 1 to level 2 at the most. It's just getting the organization in place and getting all the hospitals who want to do the right thing to get some leadership directed, so we're not herding cats and they can all join a plan, is much better. And that's why we actually have government officials, and we want them to do things in situations like this. So I do want to say I'm glad the governor's office has responded. What he did say, though, that there's capacity, there's lots of healthcare workers, and we're not in any kind of shortage, is completely incorrect. All the hospitals are very short-staffed. The staffs are very exhausted. It's a complete misstatement by the governor. And the idea that there's lots of beds available is a complete misstatement. But that's what Governor Stitt does. So that's just how it is, and we just have to know that the real truth is far different, or the truth is far different. But thankfully, the hospital organizations are bending over backwards. The providers are doing everything they can. We get great care here in Oklahoma. I mean, I would argue if you were going to get sick with COVID, better here than anywhere, because we have the best doctors and the best nurses and the best hospitals, and we have great leadership from all these different hospital administrators and Patty Davis fighting the good fight. So a lot of credit out to all of them. On a national level, we had, I think, 61,000 new cases yesterday. We're over, by one group I use to keep track, we're over 225 to 226,000 deaths. That's going to keep on going up now for the next several weeks to the next month, and we'll just have to see how this surge goes. Again, remember, COVID is going to prosper at 42 degrees Fahrenheit, and what happens in the fall is, even with doing masks and doing social distancing and trying to have less people around, the viruses are more infectious. This is when they proliferate, and so it's harder, even with people doing the right things. And so people doing the wrong things are going to be much more susceptible. Secondarily, I always want to point out now that lockdown strategy, sheltering in place, and all that stuff was never meant to be a first-line strategy, which is what it's being used for now. That was never their intent. Anyone in public health would tell you they're mitigation strategies only to slow the disease so you can learn about it and then do something to actually stop the disease or do something that could help. We aren't doing that because, again, and for those of you who get mad at me for saying this, why criticize Fauci and the FDA? That was their job, and we're not doing that. So we're still using lockdowns and things like that, which is just stupid when we have information about vitamins and Plaquenil and antibiotics. So again, that's just kind of my take on it. For what it's worth, why not do things that actually are going to work and prevent people from needing hospitalization? Why not do things to augment immune systems? So that's a preventive strategy that actually would be very helpful, because again, the nutritionally depleted, the super sick are the ones who usually get this. But again, people get it who are very healthy and also have bad outcomes. So that's kind of the summary tonight. I think I'm glad the state's moving forward. And again, it's all completely based on the good intentions of our hospitals and the hospital administrators. So if you know a hospital administrator in this state, be nice to them. The executive teams and chief medical officers and all the leadership is what's really making the state be protected. It is not the state government. Do not believe for a second that Jerome Loffridge and Casey Shrum left on the same day in July from the COVID task force at the state level because they were impressed with how well it was being run. Likewise, there's a reason we have an epidemiologist that doesn't even do human epidemiology. I think we're the only state in the union who has that. That's an accomplishment unto itself. So that's where we're standing. Kim, what questions do we have? Well, there's a bunch of questions we're going to do tonight.
Okay, lots on supplements. How much elderberry if somebody's going to take elderberry?
Elderberry is usually, again, we reserve elderberry generally for, if someone's traveling, I like to have them do an elderberry zinc lozenge as they're traveling, because it's turning out airplane travel is really very, very safe. But if you get infected or you get a cough, cold, congestion, that's when we really encourage the elderberry. It's 500 milligrams roughly 3 to 4 times a day for 3 or 4 days right at the beginning of the infection.
What about people that like to take it for prevention?
Probably 500 milligrams twice a day would be fine. You don't need to do it 4 times a day for prevention.
Okay. What are your thoughts on low-dose aspirin?
Well, low-dose aspirin is a discussion with your primary care provider or your nurse practitioner or your PA. If you get infected with COVID, there's probably a potential role, but again, fish oil might be good. The U.S. Task Force of Preventive Diseases for men, over a certain age with cardiovascular risk factors should be on a baby aspirin. Women is completely different because it can increase the risk for hemorrhagic stroke. So it's a very specific subgroup of very high-risk cardiovascular patients for baby aspirin who are women. So again, you need to talk to your provider, but at the very least, if you get a COVID infection, I just was talking off the phone with someone who's younger, he's 30, who has a COVID infection. And my number one thing, besides having him do a zinc pulse today, was I asked him to start 1,500 milligrams of omega-3 twice a day for the next 2 weeks, because even though he's not that sick, he still has some risk for a thromboembolic event. And we want to really get those platelets to get the right phospholipids on them so they're not that sticky. And if you do that for 2 weeks, you're going to keep them on kind of at a lower risk of stickiness. But again, you need to talk to your providers. I'm just giving generalized comments how I approach it, and you can talk to your provider and try to get some information from them.
Is krill oil better than fish oil?
No. Krill oil many years ago was a triglyceride. So when you think about fish oil or any oil from animals or plants, they're triglycerides. But when you took a fish oil and you purified it, it went through several steps to get purified enough to take, and it was I think originally hydroxylated, and then it got purified more to esterified, which was a very purified form. But esterified omega-3s didn't absorb as well as krill oil, which was naturally a triglyceride after processing. The problem with krill oil 15 years ago, though, is they'd come in very small dose tablets, but it did absorb better. Now, good fish oils are all triglycerides, like the one we carry is a triglyceride, so you don't use the krill oil. And one of the reasons you don't use the krill oil is it's a very specific issue. Krill are the basis, or kind of the bottom level of the ecology chain in the ocean. So if we overharvest them, we wreck the ecology. And I just, that's why one of the reasons, since we now have triglyceride fish oils are rampant everywhere, it's very easy to get, and the price points come way down. You try to avoid the krill oil and just use a purified triglyceride fish oil.
Okay, and then based on your last video when you talked about going after being on zinc for a while, then going to every other day. So a couple of questions. If you're taking a multivitamin every day that has zinc in it, can you still take that every day at a lower level?
Yes. The issue is when I was initially going over zinc, we're using data sets and information that's available then and the best science we could possibly have. So it looked like 50 milligrams a day was extremely effective, and it was extremely effective. The thing we've learned now, though, is, as I had been telling people for the last several months, if you've been on a steady dose of zinc for 2 months, you can go to 5 days a week. Well, it turns out we can actually go to every other day. And so 4 days a week, basically. So every other day gives you very good absorption, and then your intestinal tract can be very, very absorptive if you do the zinc pulse. And that's what the newer data that and suggestion from Dr. Norman Imes, who's brilliant, and I listen to what he says and read the journal articles he says. So I'm imitating what I consider the most brilliant, some of the smartest people I know. So that's where we've gone, why we've adjusted to an every other day regimen just in the last week, from doing it daily for 2 months and then going to just 2 days or taking the weekends off. But if you're taking a low dose in a multivitamin, which is usually somewhere around 5 to 12 milligrams, that's fine to continue to do.
Would you get the same results if you were doing a 20 or 25 zinc every day, just for the sake of doing the same thing every day? Is that the same as doing a 50 every other day?
I think what we're looking at is once you've been on the zinc for 2 months, going to every other day is totally fine, whether it's 25, 30, or 50.
Well, her question specifically is, can you do 25 every day?
You can do 25 every day. I'm okay with that. I think it's totally fine. What we are learning, though, but I still want people who've been on it for a couple months to take the weekends off. Because again, we want that pulse of absorptive capability to increase each week. So I would always take 2 days off the supplemental zinc separate from the multivitamin once you've been on it 2 months, because then your alpha interferon's sky high.
Can you take zinc when you're on antibiotics?
Yes.
Okay. I'm trying to keep all the supplement ones. Okay. If you have normal vitamin D levels on lab work, do you still recommend taking 50,000 a day?
No, it's 5,000 a day, not
5,000,
50.
sorry.
And so normal lab levels is a joke, okay? It's a reference range. They're not normal. So the reference range for zinc is 30 to 80, and optimal is 80 to 100. It's 80 to 100 is what we're aiming for. Now, if someone's at 70 or 75, that's great. But you get the maximal events with zinc in terms of antidepressant, cardiovascular protection, bone protection, immune protection at 80 to 100. So that's 5,000. And 5,000, if you look at the original and the best data, and again, this is not being selective and ignoring bad data. This is the true data for 5,000. It minimally adds 2 years to your life. If you're a North American or Northern European Caucasian woman. Now, men probably get a little bit bigger benefit even, but it's more for cardiovascular risk than the women do. So that's the answer to that. I recommend 5,000 a day. Now, if you're under 125 pounds, 5,000 a day after a month, I'd start skipping the weekends.
What are your thoughts on essential oils in COVID?
I think, so essential oils, just, again, they're just fats, and there's tons of lipids in our skin. So when you put essential oils on your skin, the ingredients inside will absorb quite effectively. And so I have a tendency to use essential oils sporadically, more so for anti-inflammation with, for example, frankincense. There is no data to support their use in COVID or for COVID prevention. I think essential oils are wonderful things, but I would not and you're fine to use them, but I wouldn't use them in lieu of some standardized supplements for making your immune system in its best possible shape.
Where did the 6 foot distant guidelines come from, and do you have any papers or any documentation on that being effective?
The 6 foot distance guidelines originally came, I believe, out of the CDC. I think they're very whimsical and arbitrary. I think if you look at the cough data, we all know that the COVID particles aerosolize up to 20 feet, but the greatest concentration is in the first 3 to 6 feet. And I think that's the concept. But I do think a lot of these recommendations are very whimsical and arbitrary and not based on, great data. So 6 feet, yeah, if you're closer, but if you're 7 feet and the person's coughing, you're inundated. And it can go up to 20 feet within other, this is kind of old news, 30 to 60 seconds. So no, being in a room with someone with COVID can get you infected, even if you're more than 6 feet away. But they had to make a cutoff that was at least based on some rationality, which is most of the particles with breathing are going to stay within 6 to 10 feet. I don't know if that answers the question that well, but it's a whimsical and arbitrary cutoff.
Okay, and then in your last video you talked about using cipro, and people were questioning if you're still comfortable using cipro.
I'm terrified of ciprofloxacin. That's why we use it. No, of course we're comfortable using cipro. One of the things you have to understand is when you're listening to someone like me, I'm telling you what I do. You don't have to listen. And ciprofloxacin, I've used thousands and thousands and thousands of times. Yes, there's some warnings on it. But what we're talking about now is potentially adding ciprofloxacin to someone who has a COVID pneumonia. No, secondary pneumonia after COVID with the bacteria. We don't want them to die, or get hospitalized. So the goal when I'm making the judgment of what to add to someone, whether it's doxycycline alone, and again, this is how my approach is. Other doctors have different approaches. Some people just use the Z-Pak. We've moved from that to doxycycline just because of, as much as anything, politics and other stuff, because the doxycycline actually I think gives better coverage for the walking pneumonia, which is the most common secondary infection. And number two, I think the cipro covers most of the other bugs way better than anything else. And so we use ciprofloxacin. Now, yes, there's warnings to all medicines. That's why you don't use them whimsically and arbitrarily. It's a rational decision. We make the choice based on how the patient is doing. I put someone on cipro and doxycycline last weekend, along with dexamethasone. It worked marvelously well. Did I do it randomly? No. They had increasing respiratory symptoms after being on Plaquenil for 2 or 3 days and getting a wheeze. So I thought, well, we're going the wrong way. So we have to add something. And so 24 hours to 36 hours later, they were significantly better. And it may have been more the dexamethasone than the ciprofloxacin and doxy, but I can't put a little spaceship in their lungs and see, oh, they have this bacteria, and this level of inflammation. That isn't how medicine works. You have to address the clinical situation and figure out what are the most common things they could have that could make them get sicker and make an intervention. That's why, that's a great question in many respects, because it gets to when people respond like, why would you use ciprofloxacin? Why do you think the doctors don't want to treat you? Because they don't want to get criticized. You got to remember this. It's not easy treating people with COVID because you have all this negative stuff from the FDA over here saying Tylenol only, Tylenol only, Tylenol only. And then people like me who are trying to help people and doing the best science we can. And, oh, you said cipro, it's so awful. It could be so awful. And how could you feel comfortable doing it? I'm a board certified OBGYN who knows what they're doing. So I make those judgments based on the clinical situation. So that's what we do. But that's part of why there's a problem for doctors, because the first thing they're worried about if they put you on Plaquenil is you go to the ER because it didn't work well enough, and they're like, oh, the ER doctor's going to go, he put you or she put you on Plaquenil. Why did they do that? Which doesn't happen all that much in Oklahoma City, but it does happen. So then that plants the seed in your mind or the family's mind when they hear that, oh, they should have never used Plaquenil. And that's what happens with all this stuff. So just try to remember, medicine is not just science. There's an art to it and knowing what to do.
Okay.
And I'll get off the pedestal. Sorry about that. I apologize.
What is the best COVID test? PCR, rapid, antibody?
The best COVID test is a swab. Their sensitivity runs 50 to 80%, which is pretty amazingly bad. But that's what they are. The rapids are probably about the same, or well, probably even less. The antibody tests, we really don't know how accurate they are. I think if they're positives, we believe them. If they're negatives, there's definitely people who are missed. That's not a great answer, but the tests aren't very good, and that's how it is.
Do your supplement recommendation actions change after a person has recovered from COVID? Or should they do all the same things?
Our supplement recommendations change because once you've had COVID, we're gonna probably be in a recovery phase, so we'll do things differently, which is a whole separate subject. But the baseline of a multivitamin, fish oil, vitamin D all stays the same. I think we still want you to do some level of zinc because we're in flu season, and then there's other things we're going to do to help someone depending on their situation.
This is totally off of supplements. This person has received the first pneumonia vaccine, and they're wanting to know if it's safe to continue right now.
I think it's safe to continue right now and if they're getting one that's a two-part. There's been, again, the flu vaccine stuff is so complicated to me in terms of, is it effective, is it not effective, has the vaccine, I mean, this just happened in South Korea this last week. There 5 million of their doses, and this is the stuff that happens. 5 million of their doses weren't kept refrigerated and shipped to clinics and all over the country. So they're totally inactive. I mean, it's just, and they don't really know which ones they are, and it's just a mess. And so, one, it doesn't work that well in the first place, and two, if there's a logistics problem, it's even worse. They've also had 5 deaths with the flu vaccine, associated with the flu vaccine in South Korea this year already. Now they've given 8 million so far, 10 million. So we don't know if that's a true association or not. But again, it's a little concerning. And so again, the flu vaccine stuff's very hard to talk about because it is so unbelievably complex and the data is so incredibly bad. So I will post a definitive article summarizing it, which I've outlined, and we're trying to figure out how to actually put it on. We may put it actually on our website. Because I can't really post it because I've edited it, and well, I didn't edit it. I highlighted the parts that were important in yellow, and so we're trying to figure out how to put it on. But I will put on actually the link to the unedited or unhighlighted version. But it gets pretty complicated. So
once we get it on the website, I can send the link to YouTube and Facebook.
Okay, so we'll do that. But I'll put the article on tonight, and it's a very awesome article. It's just very complicated.
You had a couple of people ask about the study.
Oh, the study, yes. I was supposed to get the phone number, but I didn't get an email on it. So hopefully tomorrow. Okay, thank you. Good night.